All right, hello and welcome to the M&M podcast. I'm Isaiah Moser.
I'm Sarah Martinez.
And today we're going to be talking a little bit about cardiac arrest. So, Sarah, tell me first, I think for our listeners, what is a cardiac arrest?
So cardiac arrest is what I picture when I walk in. The patient is non-responsive. They're laying down, or they could be sitting up too, but they're not looking at you. They may be slumped over, eyes may be closed, and I go and check on them, and they're not breathing. I can't get a response. I check a pulse, and then I call a code. But basically, the heart has stopped beating, loss of blood pressure, pulse, respirations, and so forth.
Awesome. So I'm going to pull that back too. So let's look at our learners too that are outside of the hospital. This is any time that we have a sudden loss of consciousness, loss of pulse, wherever you are. And we're going to go through some of that today, the activation of the team, what that looks like, what our outcomes look like, and what we need to do as the nurse. So going back to your hospital, so your patient's lost a pulse. Let's go through some of those rhythms. So what heart rhythms are associated with the loss of pulse?
Okay, so I think at the V's, ventricular tachycardia, ventricular fibrillation, asystole, and pulseless electrical activity. Do keep in mind ventricular tachycardia can have with a pulse and without a pulse. So that's why it's so important to check your patient, not just the monitors, but assess your patient.
Awesome, awesome. So if we were to break down each rhythm, let's start first, VFib. Okay. Walk me through that one, because I think sometimes too, like not just for testing, but just for our knowledge, like you have to be able to see the rhythm, but also like be able to describe it. So what is VFib?
So the easy way to that I identify it is it's a chaotic rhythm. I cannot identify a P wave, a QRS, or T wave. And it's just like a bunch of bumps, and it can be fine or coarse. It's not tall, VTAC is tall, but it's, a bunch of bumps, and you cannot identify the P wave or QRS or T wave. And when I see that, yes, it can be artifact, it can be false, so that's why it's important to check your patient and the leads, the telemetry leads, and make sure that they're responsive, breathing with a pulse. If they're not, and you check all that, then it's most likely they're in ventricular fibrillation. And ventricular fibrillation is without a pulse unless there's something going on with their leads and they are responsive.
Good, good. So to highlight, like you said, VFib, there's never going to be a pulse. And now when we compare that to VTAC, if we were to describe that one, we have that tall, like tombstone appearance.
Yes.
That's a rapid heart rate originating from the ventricles, and that one can be associated with a pulse.
Yes.
So, going through that, walk me through that. How is our treatment going to be different if they have VTAC with a pulse versus VTAC without a pulse?
So ventricular tachycardia, when you identify it on the monitor, it's going to be tall, tombstone. It can be wide and narrow, but you don't see a P wave or a T wave. It's just usually a wide, or narrow QRS. And, the T waves and P waves are non-discernible. They could be buried in there. There is some cardiac output. The blood pressure can be good, but the pulse is rapid. The issue with a rapid pulse is the heart's not filling appropriately, and they can eventually lose their blood pressure and have no pulse. So I check my patient, see if they're responsive, and if they have a pulse and they're breathing. And if it's with a pulse, usually what I see it is that they are still responsive. They just may be confused, they're uncomfortable, they feel a palpitation in their chest.
Awesome. So, and then we're going to go through the meds a little bit later, but the meds are going to be a little bit different on those two rhythms. So let's walk through the last one. It's probably the easiest one to identify, asystole.
So asystole, there is no cardiac output, no pulse, no blood pressure. There's no identifying rhythm. It's just a flat line. Yes, it can be false. It can be artifact. How do you know that? Check your patient. Are they responsive? Pulse, breathing, and so forth.
The other thing I always tell the students, like if you see the solid line, it's asystole. If you see the line with the little hash marks and there's like a little space, it's because you don't have your patient on the monitor, right?
That's a good one.
So never think that your patient's in asystole. Like if they're talking to you,
they're
minus ECMO. I'm not talking about ECMO right now for anyone that knows this. That like if you have the spaces, hook your patient up to the monitor because they're likely not on the monitor.
Yeah.
So looking at the cardiac arrest, and we talked a little bit about this today already, the numbers aren't good. You know, the numbers are never good. They never have been. We've usually seen below 10% for out-of-hospital cardiac arrest. Now, in-hospital is obviously better. Walk me through some of the reasons why you think out-of-hospital cardiac arrest is so low.
It just depends on that time where that individual is at, and if there's bystanders that perform CPR, perform the chest compressions, and they activate the emergency response team, which is your EMS, your paramedics and EMTs, and they come in time. Remember, time is life, time is heart, time is brain. So and also it depends on the individual. What are their comorbidities? What is their overall health condition at that time? If they have a lot of comorbidities, they have poor health, they may have a lesser chance of survival too.
Yeah, and I was looking at, when we were preparing for this episode, like the out-of-hospital cardiac arrest, only about, and out-of-hospital, just so that everyone knows the terms, that could be at home, and it actually includes nursing homes in that too. The amount of bystander CPR is only about 40% of patients receive CPR prior to arrival of EMS. So that's a big component to this, is that, you know, you look at the average response time, like even here, where we're situated in Orlando, is at least 10 minutes. So if the patient does not get good quality, high quality compressions for 10 minutes, the likelihood of them coming back goes down. And the AHA, which is a big association we use here, they say if bystander CPR happens, it increases 2 to 3-fold the survivorship. So, you know, as nurses and as our nurse learners that are growing into nurses, what is something that you feel they can do to like improve those numbers? So what component did they play in improving the education?
I would definitely take a CPR class. As healthcare providers, we do the American Heart Association. That is known, its credibility. So I would recommend American Heart Association to take that BLS class, basic life support, and practice on the mannequins, practice that CPR on the mannequins. When you practice and simulate, and you even anticipate in your mind and plan, it will go better. Yes, it's not gonna be perfect, but it will go better. And when you are coming upon someone and they're non-responsive, you check them, are you okay? No breathing, no pulse, you check their carotid artery. And they're an adult, you call the EMS, and then you start CPR, you do your chest compressions. Now, if someone is with you, they can call the EMS and you start chest compressions. If you're by yourself, you can skip the mouth. Do be careful because of, you know, transmitted diseases. If you're worried about that, I understand, so keep yourself safe. But chest compressions is key to pump that heart and get the blood flowing, and whatever oxygen is in the blood will help that perfusion and oxygen. And keep in mind, we did Stayin' Alive song. That still applies. I know the chest compression rate has gone up from 100 to 120. You can also do the Baby Shark song, the Pink Pony Club song, but just, you know, keep your composure. I know it's tough. And take a deep breath and then start your chest compressions. And about 2 inches. You do want the chest to recoil, so that means when you push down, you lift back up and let that chest, you're getting that heart pumping.
Awesome, and you guys all should have already taken a BLS class, and so it's important to, you know, preparing our community. So whether that be you guys take an instructor course and then teach others, or you encourage people to go to hands-only CPR, like what she's talking about, that first 2 to 3 minutes of the cardiac arrest, they're still circulating oxygen, it's just not moving. So good high quality CPR, even without oxygen delivery, is still better than nothing. And then just knowing the outcomes, which we're gonna go through in a little bit, but you know, looking at these patients that go into sudden cardiac arrest, which is one of the leading causes of death, right? So heart disease is up there with cardiac arrest. What are some of the risk factors and modifications that patients experience or that have prior to a cardiac arrest? So what are some of those risks?
Lifestyle, diet, exercise, you know, our weight, cholesterol, blood pressure, stress. Trying to think what else, what other modifying factors you want to throw in.
Yeah, those are good. Yeah, just keeping, like our patients, it's like you do the triple. Did you ever learn like the triple H's? I like to teach like the hyperglycemia, hyperlipidemia,
Diabetes.
and then hypercholesteremia. So they have high cholesterol, diabetes, and they're overweight, right? So, you know, if you put those together, now we have like fancy terms for it, like metabolic syndromes.
Metabolic syndrome.
But if you put all those together, that's what's causing it. And I think we may see a good reduction in a lot of these issues because of our fancy new GLP drugs.
Yes.
You know, because a lot of our patients now, they're having good weight loss from just medications, and they're not needing to do like these aggressive exercise regimes to do it.
Because we do understand that sometimes genetics plays a role with your profile, so and with your weight and cholesterol. So it is tough to get improve your health and become healthy. So it's okay to use medication, but always consult your provider. They know you best, and you work with them and advocate for yourself. And with these GLPs, I have noticed it's becoming better controlled. You can do microdosing. Look at the adverse effects, contraindications. It's not for everyone. So it's okay, you know, it's an individualized journey and plan of your health. So don't feel like you're missing out either on doing the GLP. Do what's best for you, but always research, look into it, and, you know, collaborate with your healthcare provider.
Yeah, and I always think it's funny. Like I always tell my patients when I'm educating them on if they want to do a GLP, right? Say they're, you know, BMI of 40. We want to put them on a GLP. And they say, well, what's the side effects? And I'm like, well, the side effects of being morbidly obese are really high too. You know what I mean? Like both sides of that argument have side effects.
They
right?
do, yes.
So moving back to where we're at with the code process and getting our outcomes, if we were to walk through the perfect symphony of an out-of-hospital cardiac arrest, and I was thinking about this earlier, what is like the perfect way that the system would work? Is you are on, say, a basketball game or something, and a person goes down, and I'm like thinking of this because this is what happened. So you have someone go down, the emergency response team is activated as an EMS, right? 911 is called, an AED is available, the person receives a shock prior to EMS arrival, right? And you know, then they get to EMS transports them rapidly to the hospital. They identify what caused the cardiac arrest. They're in the hospital 3 days. They come home. That's like the epitome.
And what he's saying is like at a basketball game, you have people there, you have help there. So someone can call EMS, some can start CPR, you can rotate CPR with people, rotate chest compressions. And it just flows because you have a team there, just like the hospital. You have a team there, so it flows and smoothly, and you can have more effective intervention.
And when you look at it, like we talked about these rhythms earlier, the only thing that's going to get a patient out of a lethal rhythm is defibrillation. And so as much as we're preaching it and as much as, you know, we hope our nurse learners know this, like CPR is great, but we need an AED. And time and time again, we've proven that AED is what really like is the difference maker in between like if a patient has a great chance of survival, right? Because the longer, and I wish I would have brought this study with me, but I can attach it. The longer a patient is in refractory VFib, the lower chance of good like mortality numbers and good neuroprognostication after they get into the ICU. But early shock continues to be where we want to be. And so what does that look like? As I have to be careful because I always think about a hospital, but in the hospital, how do you get an early shock?
So early shock, so just to clarify, ventricular fibrillation, VTAC, even though we are doing chest compressions, yes, we need that. They can still be in that rhythm, and it's not a good cardiac output. They don't have a pulse, you know, depending on if it's VTAC or VFib, and with a pulse or without. But it's not a good cardiac output or no cardiac output. And so we have to knock that rhythm out and then have the heart restart. And we're hoping when it restarts, it has a good organized rhythm because that's a good cardiac output. And so what does the early shock look like? So I walk into a room, the patient appears to be sleeping, and I'm going to do my assessment. And I said, hey, so-and-so, and they're not responding. So I shake them. And then I may do like a little sternal rub, and they're not responding. The monitor may be alarming. This depends on if they're on the telemetry monitor. I check their breathing, check their pulse. I realize they have no pulse, they're not breathing. I hit the code button, a team comes in, someone brings the crash cart. I may already be doing CPR, chest compressions, and someone brings the backboard. We roll them over, put them back on the backboard. The backboard helps facilitate good, solid chest compressions. They're not bouncing in the bed. And then we start hooking them up to the actual defibrillator, our own monitor system. Just like the AED, but we have more control because we see the actual rhythm. With the AED, you cannot see the rhythm, but the AED will diagnose that rhythm and let you know whether it's shockable or non-shockable. And when we hook them up to the actual monitor on our crash cart, we see the rhythm. We can actually, stop once we get the charging, the monitor charging, and we're ready to shock. Then everyone's off the patient, everyone's clear. We can do an early shock. But it's nicely flows because you have a team there in the hospital. You have your crash cart, and it just works so smoothly. Yes, people are, maybe a little high energy, adrenaline's pumping, so that is expected.
Yeah, and she brought up 2 points. So one, the AED will not shock asystole, so don't worry about that. So like I got so excited, like the cardiac arrest I'm thinking of when I was like not at work was like when the AED say shock is advised, and I'm like, oh, cool, we have a shockable rhythm. Like that's exciting because then we know like the patient's not in asystole, right? Because you don't really know, like if you think about it, if you're out in the community and your patient's in VFib and you're doing compressions, the only way you're gonna know that they're in a shockable rhythm is the AED telling you, right? Because the AED will analyze the rhythm through the pads, and it'll say, hey, shock is advised, and then you know you have a shockable rhythm, which is interesting. It's fun. The cool part about it, too, the case that I'm referencing and thinking about, is once we got a organized rhythm back and the patient started having a little bit more of a regained consciousness, then the AED says, no shock advised. So then you know you're either one of 2 things. No shock advised means you're in an organized rhythm, the patient has a pulse, or they're in asystole. So it kind of, like, even though we wouldn't teach this to like the layperson, if you would, it's good for us to know because if we're on a scene of something like that, then we know. And the other thing to think about, the other point you brought up when you were talking about it, you said like, hey, as a defibrillator, we have more control. And all of you, that are listening, a lot of you will be ACLS certified. But even in most scenarios, if you're not controlling the shock joules, if you will, you can still use all of those monitors as AEDs. So even if there isn't a provider present where, like if your hospital protocol says, hey, a provider has to be present to dial in the joules, you could just do an AED. So, the AED, whether it's in hospital, out of hospital, is highly functional.
And the AED is the automatic external defibrillator. So that's what it stands for. And again, it won't shock asystole, but it'll shock those rhythms that do not have a good cardiac output.
So I asked Sarah today, I said, hey, let's come up with a case. So tell me a case that would help seal this for the learner that you had where you had a great outcome.
So we're doing our assessment. I did have a nursing student with me.
Of course.
And
that's how it goes.
It does. The patient was really sick, and they had a history of cancer, and that was part of why they were sick and why their electrolytes they're imbalanced. And the potassium was high, and if you have either a low potassium or high potassium, they can go into a dysrhythmia, VTAC, VFib. He was in AFib, I think, not RVR, but controlled AFib. And then I just looked up at the monitor, and here he is in VTAC. And I'm looking at him, using my inspection, he's not moving. So I'm like, oh, let me check your leads. And he's still responding to me. He just doesn't look good because he is sick. And the leads are great. And I realized he's in VTAC. And so I did call for help. This is not recommended. This is like old school. But I did pericardial thump him in the chest. And we don't do it, especially if they've had heart surgery or any incisions to their chest, because you don't want to disrupt that. It did work temporarily. He went back to AFib, and then he went back to VTAC. And so we were looking and we knew his potassium was high. We were hooking him up to our crash cart. The charge nurse came in and we called the provider. We were grabbing insulin and dextrose and calcium gluconate. Insulin will help push the potassium into the cell, and so the plasma will be lower with potassium because that's what's causing that VTAC at the time. And he kept going in and out of VTAC, and eventually he was unresponsive. So we did actually do CPR. I was trying to remember if we shocked him. We may have shocked him, but he actually kept squeezing our hand off and on throughout the whole code. We did eventually get him back. We did our temporary measures to lower his potassium with the insulin and dextrose. Dextrose because the insulin will lower the sugar as well. So we don't want to cause hypoglycemia with that. Calcium gluconate just helps stabilize the cell from being so excitable. So that's what your measures are. Insulin, you will draw it up with your actual insulin syringe, and then you'll transfer it to an IV push syringe because you want to make sure you have the accurate dose. So just be safe with that. Check with another nurse. Yeah. During a code, I want to say do not feel rushed because you don't want to make an error. So always check the dosages, check what you're doing because you want to, still have a good patient outcome. Just, slow down. And also they may have allergies, so always check that.
Yeah, and she brings it like right at the end, a good point there about the staying calm. So I know I say this, but like a cardiac arrest, the beauty of it is to not be scared as an initial nurse because you can't get anything more than dead. Yeah. And like they're starting off dead. I've
said that to a student. The big thing you want to know is their code status too. He was still a full active code, so that's how we knew to start CPR and call a code. With his VTAC, we were going to cardiovert him, but then he went on non-responsive. Cardioversion is a controlled defibrillation, as I kind of think of it that way, where we want to shock him on his QRS, because then we're hoping that'll convert beautifully to an organized rhythm. Even AFib is still a good rhythm, we'll take that. And that was his baseline. But we couldn't cardiovert him because then he went no pulse, non-responsive. So then we had to go to regular defibrillation. And cardiovert, just make sure you hit the sync button. That's what you want to hit.
You see the little triangles above every QRS, I used to have a paramedic instructor. Obviously, we don't teach this here at UCF, but he used to say, well, just shock it till you recognize it. And I'm like, it just used to be a going joke. Yeah, like eventually everyone's rhythm's going to end the same, asystole, and you know how to do that because that's just CPR. Yeah. But we have to be mindful. The biggest risk that she's talking about, if we defibrillate a rhythm that should be cardioverted, they're going to go into VFib. Like that's the most likely cause VFib.
It's not landing on the QRS, so it can land on the T wave, and that's your repolarization of the heart, and that can knock it into ventricular fibrillation. So.
Yeah, so I wanted to walk you guys through because I know a lot of times as you're preparing for a test and you're sitting there like, all right, every question I get is, what's the priority? What do we do? So like a stepwise approach, right? You have a patient unresponsive on the ground. We are following BLS. Can you hear me? You check a pulse.
Forget that BLS.
Check a pulse, look for breathing, 10 seconds max, and then we move on to the next step, which would be activating the emergency response. So I want to stress that. Activation of EMS and pushing code buttons comes before doing anything else.
Yes.
Because you could be a really good compressor, but eventually you're going to need someone else there.
You're going to fatigue out. Yeah. We do need that defibrillation if it is a chaotic rhythm. It's just a better outcome as a team.
Yeah, and a lot of times, even when I reviewed cases, you'll see this all the time. Bystanders will do great compressions. They might even go to the AED, and then they sit there and they're like, wait, who's calling 911? So you might have worked this whole beautiful everything, but you're not getting the people there. Yeah. So that's why a lot of these organizations, not just AHA, there's other ones too, Red Cross, for example, that activation of personnel is important. So in your hospital, you guys are going to be pushing your code blue button. If you're at a public health clinic, you're going to be calling 911. If you're working at a nursing home, you're going to call 911. All those places, you have to bring the resources to you. Yeah. And then if you're in the ICU, you might be the resource. So you might not do that. So just a little caveat, some ERs work their codes within, they don't announce them. some ICUs work them within. So.
This is true. I've done both. So I worked ICUs where they do call it or they don't call it, or they need more hands, so they'll call it. Just know your policies and protocols. Yeah. It's okay if you hit the code button. Don't feel bad because you're keeping your patient safe. Yep. I've even hit it where I've seen them really decline rapidly, and I'm like, oh, they're gonna code on me. I need help. So I hit the code button. So don't feel bad. Like, should I have hit that button? You're keeping your patient safe. And they can always change it to a rapid response. They can always say, cancel code, you know. So.
Yeah, and that's something I've done too. Again, I've told you this story, and I'm not gonna put it on here, but basically, like, I had a patient before that needed to be intubated. And it was like, not like it needed to be intubated tomorrow, it was like now. And so like, that's a moment where if they don't get intubated, they're gonna go into cardiac arrest. Yes. So I activated the code. And a lot of people say, well, why activate you know what you're going to get with a code, right? You're going to get someone to manage an airway. You're going to get team members to help. You might get a pharmacist, but you get more people. And like, we know that outcomes are going to get better, like if you have people doing things. So, you know, looking at that from the perspective, don't ever feel bad for upgrading care, because it's much easier. And I know I talk to you guys a lot, and we've talked about it. It's much easier to downgrade and not have a patient issue than having to upgrade later. So if you upgraded care and said, hey, I think they're really sick, I need help, and then they ended up not being that sick, you can always take away some of that stuff. Yeah. But if you don't call, then that's where we get into that failure to rescue. You know what I'm talking about.
So failure to rescue is also time. It's also not recognizing, oh, they're declining, they're deteriorating. Should I call for help, call a rapid? Yep. It's time and activating the response team. It could be the code team, it could be rapid response. I'll give you an example too. You know how new hospitals are set up, they have long hallways. Well, I was at the end of the hallway and someone notified me, hey, I think your patient next door is having a seizure. And in my head, I was like, you know, I did run over, and in my head, I was already going through, I'm like, this was not in the history or what report, so this is a new seizure. So I realized I need help. I just made sure my patient was safe, and they were safe. Safe meaning, are they gonna fall over on the floor? Yeah. Where are they located at? So your big thing is always remember, think safety, check the scene. We're not gonna shock in water, just to let you know that. So always check your scene, make sure there's no wires, electricity, because if you get shocked by electricity, you can't help them, and now you're in trouble. So always check the scene. So I was checking the scene, making sure the patient was safe. They were actively seizing. I actually called my charge nurse, and I said, hey, the patient's having a seizure, I need help, we need to call rapid. And I could have called rapid myself, but I knew my charge nurse was available, I just saw her. She called rapid for me, and we all went down, you know, they all came down and helped me with the seizure. Thankfully, she did not turn into a code, but seizures can turn into a code. So.
It made me think of, there was a study that recently, I don't think we do this here stateside, but I think it was in Canada. I'll have to put it on there. But basically they did a code, but they would, you know how like we say don't touch the patient? They would hold the pads as it was shocking to get more penetration into the heart. And it was interesting. They actually stopped the study earlier because someone got shocked. But
so except if you don't have your fingers just right on those pads,
yeah, like you're gonna get shocked.
You're gonna get shocked. Do not.
Yeah, so don't do that. That's a big don't do it, right? That's just this is just for education. But it was interesting because like, and you will probably see it October. The new AHA guidelines come out. I think we're gonna see more push towards like anterior posterior placement for good penetration. Yes. You know, going from the front and the back rather than, because you know this, like the lateral. It's a lot of times it's not placed right, and so then you don't get good penetration, and so then like you might not have good shocks. But anyway, we wanted to go through the meds too with our learners today. So walking through them, basics, right? So VFib, VTAC without a pulse, asystole, they're all gonna get epinephrine, right? So that's like our...
Also, another way is EPI is for short, but epinephrine. And that, your body makes that too. So we are using that, and it's also known as adrenaline, so we are using that.
And I'm gonna tell you guys, there's no like really great studies on any drug we're gonna mention. So like all of them, we hope that they're doing a lot of good, but like asystole, the chance of coming back, and I think I said this at the beginning, but like less than 10% of out of hospital come back. And then like of that 10%, probably like 2 or so is like asystole on presentation. So, you know, asystole rhythms are really hard to get back. We only have epi. Now, our other rhythms, like VTAC with or without a pulse and VFib, are other drug options.
Amiodarone.
Yeah.
And there's lidocaine as well. Amios are go-to. It's whatever's available too. So they do recommend sticking with one medication, amio or lidocaine, but sometimes you may have to switch just depending on the provider and what's available to you. So.
Yeah, and amio, like she mentioned, like most places are using that. AHA specifically, speaking to them, they mainly use amio, but lidocaine's listed as an option. And it really depends on what hospital you're working in. Like, I know some hospitals, the ICU team posts cabbage like lidocaine. So if you're in that building of structure.
I've seen that with cardiologists. It depends on their preference. Some don't like amio. Yes, there's side effects. If you see amio, there's a bunch of side effects, but at the same time, we're trying to have an actual resuscitation. So, you know, you have to weigh the pros and cons.
So I think the argument for amio side effects is probably more on patients that are not in cardiac. You know what I mean? Like cardiac arrest is going to be tough because they're not doing well. But we know amio like lasts in the bloodstream for months. So that's why it kind of, you know, the side effects. So epi, amio, other meds, and I think anywhere we go from here forward, minus polymorphic VTAC, which we didn't talk about that one enough. You know, polymorphic VTAC, torsades, that one will have magnesium component, but every other drug that we could talk about really is provider dependent.
It really is. I've seen providers, just based on their experience, where they trained, what they've seen, their outcomes that they've used. Yes, we have evidence-based practice, which is great. Yes, we do have that to use as our, I say like a guideline, because every experienced individual is different. So, and it just depends on that, their background. Even with ventilators, I've seen providers have different settings with ventilators, and I'm not saying that's a bad thing. You know, that's they've seen their outcomes and what's going on with that patient at that time.
And I think it's like bicarb, for example. Like I think the jury's pretty much out. Like if you look at the data, bicarb's not good in cardiac arrest. Like there's not many scenarios where I'd say bicarb's like a great option. But like if the provider feels like prior to the arrest, the patient was largely in a metabolic acidosis and their pH was super low and they thought they'd benefit from a bicarb, okay. So like I said, the other meds, she mentioned calcium earlier if you have a patient that's hyperkalemic prior. And then like I even used to see this all the time and I think it was just kind of like a last ditch effort. Like have you ever seen it where they just like give dextrose?
Yes.
Yeah, and you're like, what did...
Oh, so why? Because when you cardiac arrest, yes, sure, you have a stress response. So at the time, your glucose may be high, but eventually it's going to come down because now you have no blood flow. So they're just trying to think of any option, like let's just give them some sugar and see if that will help, you know, do something with the heart. You know, it'll help stimulate. Because when you do have, like, you think about it, when you ingest sugar, you're going to have that energy. So they're hoping the heart will just get like something out of it.
Yeah, and I think that's really just came from like, hey, we'd really like this arrest patient. Obviously, we would like everyone to have a longer human life when we're cardiac arresting them, you know, when we're working them. But like a lot of these drugs, we don't see like significant changes in their status. Versus like antidysrhythmic, like our potassium channel blocker, amiodarone, we know that that can help convert the rhythm. So that's a little bit different than like say dextrose or magnesium, right? Magnesium's even being used in a lot of these codes. So wrapping things up today, I wanted to, we walked through the cases, we walked through some of the meds we used, survivorship, what does it look like? And this is something that we've talked about before. When a patient comes in and they've been resuscitated and everything, and they come up to your ICU, and Sarah's more of the ICU person.
He does both. He is paramedic. He's out of the hospital. So I never was at EMS, but I was a CNA in a nursing home.
There you go.
And then a registered nurse in the hospital.
So she has a lot of the experience for the ICU. What does it look like when we're saying, hey, our cardiac arrest patient has come up, and I know we stress this, me and you both do in our classes, like don't say if they're gonna live or die for the first 72, you know, like that neuro outcome, like 72 hours. But in your experience in the ICU, how many of these patients that we cardiac arrest end up having like great outcomes? You know what I mean?
Oh, that's so tough. Again, what I was saying earlier, it really depends on the situation before they came in and their overall health.
Yep.
And time too, time with CPR, time to the hospital, effective compressions, medications, defibrillation.
Yep.
So that's a tough one. I say that's a toss-up. Like statistically wise too, you have to look at the evidence, but I think sometimes it's a 50-50, sometimes it's poor, sometimes it could be really good for the patient, it just depends. And if they're not responsive mentally, neurologically, they're gonna get that induced hypothermia, the targeted temperature management.
Not everyone uses that. Let's just stress that. Not everyone does TTM, and like the data on it, I think AJ's still saying maybe, but like different hospitals may use it, other ones might not. And that's kind of where we go into those like alternative TTM, ECMO.
Yes, ECMO.
You know, like one of our local hospitals now is doing it in the emergency department, which is awesome.
True.
We'd hope ECMO would transition everywhere, but it's just hard. So that's part of it. The other thing too, she brought up a great point. What was their pre-arrest state?
That's a big one because I noticed that, and I know students are asking that too, and it's just like it's really their overall condition and their pre-arrest state. Because why, like even we're in Florida, so we have a more older population, so there's more of that chance of comorbidities, a decline in health. Yes, we do have healthy older adults, but you know, once you live that certain point over a long period of time, you do have more risk of diseases, comorbidities. So you do have to know their history and their pre-arrest, because then you have a better idea. What we tell families is a day by day, hour by hour, minute by minute. There have been some that made a miraculous recovery when we weren't expecting it because they were so sick. They had that poor, health history, their poor condition. We call it poor prognosis.
Yep.
And how we know how their outcome is going to be is by our assessment too. Are they responding? What are their vital signs? Are they on high settings, receiving also vasopressors and so forth? We look at the whole picture. So.
Yeah, and I had a conversation this past week with a client too, and I think it's really important to talk about pre-arrest state, because I'm a big, it used to not be as big, DNRs.
It did, yeah.
It used to almost be like in the medical community, like a failure.
Yes.
And now it's looked more like, hey, the chance of coming back, we already know is like less than 10%.
Yes.
So is the value there? And I don't mean value on life, I mean to the patient. Like,
quality
would you
of
want
life.
to be on a ventilator on these things? So I had a conversation. It was with a 97-year-old and really bad metastatic cancer and full code status. And it's just like, I had to have that conversation like, hey, your pre-arrest state, you have metastatic cancer, all these things are going on. And like, if you go into cardiac arrest and you're on a ventilator, all we're doing is taking your same pre-arrest state, which is metastatic cancer, terminal diagnosis, and then putting you on a ventilator. Like the outcome's not going to be good, right?
Yes.
And then you take a step back, and the case I'm talking about, it was elected to continue with the full code, and then that has to be okay too.
Yeah.
So as us, you cannot put what you think is appropriate.
This is true.
Onto the patient, because it's like if they want that, we need to deliver what they want.
It is so difficult because a big thing I think lately too, we've been asking, what do you want? Like what is your quality life that you want, or what would your loved one want? And we're not saying not to try, we're just putting it in perspective. You can do the ventilator, you can do pressors, that all can be temporary, and we can discontinue it and see how you do. And sometimes they may be re-intubated, have those resuscitation measures, or we do comfort care and maintain their quality at the end of life. Sometimes they do make that recovery, but it is hard sometimes to separate what we believe, but it's really about the patient at the end of the day. And what did you do for the patient? Did you inform them? That's what we're talking about, informing and educating. They know their options, and that's all we can do. And just, we wish for the best You can pray for them, send them well wishes, you know, the universal vibes. If you don't believe in prayer, that's fine too. Whatever you want to do.
Well, you want to match the patient. So what she's saying, yeah, like, so like if your patient believes in so-and-so, you can provide that at the bedside.
You can support them, yes.
Yeah, and you could bring the people in. Like, I've made calls to like stuff I've never even heard of.
Yeah.
Said, hey, there's a client we have here. They feel that your whatever belief it is would benefit them here at the end of life.
Yeah.
Can you come in?
And we,
you know?
And we do also weigh too, like we do have to be mindful of other patients around too, with the noise level, and we have to weigh the risk and benefits and pros and cons, and talk with the team as well. We do want to support their wishes. We do.
As long as as long as it's a safe environment. And then I would shout this out to our EMS providers too. As a provider, I'm trying to make the situation match the patient needs and like the chance of survival, right?
Yes.
So like that example patient I'm giving, metastatic cancer, this and that, EMS providers might show up and the hospital might get this patient and they're like, why are we doing this?
This is true.
And I always say, like, don't think that the conversation hasn't happened with the primary.
This is so true. I've worked hospice, and I was rounding as a nurse practitioner. I didn't manage the admission. I would always come after the admission. So it felt like sometimes I was doing the admission because I felt like I was starting from, you know, point one, that, you know, the family is still gathering, and patient, they're still gathering that they have a poor prognosis, they have a terminal diagnosis, they have 6 months less to live. Sometimes they do live longer, but they're still in shock. It's like a shock state. So I feel like I'm starting over with the conversation, but it's okay because I realize they're in that shock state and they just need to hear the conversation again. So have patience. Don't act like, oh, Isaiah didn't do his conversation. Sometimes too, the conversation can't happen right away because you're in that moment of resuscitating. So sometimes someone else has to step in too and have that conversation. And it's all based on comfort level. And as a registered nurse, usually the provider will do that conversation because of your roles, and the provider is doing the orders. But if you identify there is gaps in communication, that they don't know what's going on, do identify what they know and don't know and what they want, and then you can bring the provider in to have a family conversation, to have a patient conversation. So as a nurse, always identify, use your assessment, what they know, don't know, the gap, what their goals are, and bring that provider in, the physician and P.
Yeah, and I think that's why me and you, we don't work in success and failures when it comes to patient death. It's just outcomes. Like as in like, I'm not gonna own like yes, we can all give like a high five, like, hey, we got a cardiac arrest save, but we also like should high five each other when we don't. Like it's just a good job. Like we gave the same level of care, and then the outcome might not have been positive, like the patient might have passed, but me and you did great care. So like, don't live high on the highs and don't go low on the, you know what I mean? Like just.
Even, I know that it is sad to have a patient pass away and our own loved ones, but you did all that you could do. And what was the goal at the time? If they wanted resuscitation measures, that's what they wanted. We provided it. So that is a win with the patient because we did try. It's about them.
We tried to meet them where they were.
Yes, we tried to meet them.
This is what they wanted. We honored that up to a certain level. Now don't get them on, like long. We might not be able to resuscitate forever, but so the last thing I wanted to ask you, this, and you know how I ask you on the spot stuff. 2030.
Okay.
So we're 5 years from that.
Okay.
2030. What changes do you think will be made in the cardiac arrest treatment of patients? Like, what is something you're like, I think this is going to change in the next 5 years?
And maybe part of the algorithm, the response, how we're responding, is more resources going to be available to the lay public in responding, more training. It's really interesting because you know how in the hospital there's like a triage nurse, but now they're having nurses with EMS triaging as well. So I'm just I am curious, increasing resources for the lay public, and then our algorithm too. Is there anything that we can save time on, but not saying cutting corners, but save time on to improve patient outcomes. Are we taking too long doing something? Medication-wise, is there certain ways to use the medications better? So I'm just curious there.
Yeah, and the only really thing that so at the end of this year we're going to see some new guidelines probably come out, but I think the only thing that I really would like to see, and I think in the next 5 years we'll see it, is ECMO become more available.
Oh, that's right. Yes, ECMO.
Yeah, I mean, I know I speak that a lot, but like I really would love to see cannulation be like and by that I mean like putting the wires in, getting them cannulated in their fem. Like I would like to see that completed. Like it's just another day at work. Like right now it's like a big thing. Like hey, we're putting this patient on ECMO. Like we only have 26 beds or however many beds. Like that's a big one. They might have 10 beds. And just making that like other countries have it.
So, ECMO, it will help with blood pressure, perfusion, oxygen. There's different settings of ECMO too. And
just like the initial resuscitation. So like if we can take over the body for a little bit to fix the initial insult.
Yeah.
So like, we know this, a lot of the cardiac arrests happen not because of electrolytes. They happen because they have like an unstable plaque and they end up with a heart attack and then they go down. Like that's a traditional pathway.
Yes.
And so if we get them on ECMO and then we can do a stent placement, for example, then,
that's true.
we solve the problem. It makes me think back, I should tag them in this podcast. I was working my first week at a new job and me and the other guy, we were both brand new there. And one of the clients went down in triage, full cardiac arrest, unresponsive. We pick him up, put him in the bed, get into the room, VFib on the monitor, shocked one time, IOs in, got one dose of epi and shocked once, conversion to rhythm, talking to us. Ended up getting flown out, got a cath, blah, 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 comes back, says hi, everything's fine, right? That's like one of those like perfect. Yeah, perfect cases.
Beautiful outcome.
Yeah, and I'm like how the stars have to align for you to sit down in the triage room and then go into cardiac arrest. So like that's like an example of like just perfect when things roll together. But if we have more readily available ECMO, things like that, I think that's what we'll see hopefully by 2030 to really change some of these things. Is there anything that I should ask you today?
So I just want to summarize too, because I know we were talking about dysrhythmias, ventricular fib, ventricular tach. So just to clarify, so ventricular tachycardia without a pulse, ventricular fib is without a pulse, we will shock those rhythms, defibrillate. We will do our BLS, our CPR, we'll give epi, we'll give amio. Now the tach with a pulse, since they have a blood pressure, and usually they're responsive or they're disoriented, we will cardiovert them. Yes, we can do vagal maneuvers, but if they're unstable, meaning their mentation is not good, their blood pressure's low, they're in distress, they're not at their baseline, then we will cardiovert them. We can do amiodarone too. Amio is for with a pulse too. So we do use that for VTAC with a pulse. We use that for AFib, AFib RVR, SVT. So I just wanted to clarify that. And then asystole, there's nothing to shock, so we would just do chest compressions, and we will also do epinephrine. And then pulseless electrical activity is usually an organized rhythm, so we won't shock it. We will treat it like asystole, meaning we'll do compressions and we'll do epi.
That was a good summary.
Is that a good summary?
That was a good summary. So anything you think I should have asked you today about cardiac arrest that a learner needs to know leaving? Is there anything I missed out on?
It's okay if you are nervous and you get excited, but just take that deep breath, call for help. It's okay if you get a little confused of what to do. Just make sure you do check your loved one, check your patient, see if they have a response. If you don't get a pulse within 10 seconds, their breathing's not good, start those chest compressions. Just make sure the scene is safe, that you're not going to get hurt yourself. And if you feel like you're going to get hurt, definitely wait for EMS, because you don't want to also be a patient as well. So just remember, always keep yourself safe, follow your BLS. There's reasons why the instructors highlight certain things in the courses. It's for safety too. So.
Hey, so thanks so much for joining us on the M&M podcast. This is our second episode,
Yes.
and we plan to have many more.
Thank you for coming.